be with any problems there. So
it says it's preparing, so
it's preparing. Okay. So if you can let us know, Lucy, when it's streaming.
Yeah, done, I think.
Perfect. Okay, so welcome everybody to the June meeting of Sheffield Governing Body in Public. So we'll start with apologies for absence. I have apologies from absence from Greg Fell, John McElwraith, Sheffield LMC and Nikki Normington. Carol and Jackie, are you aware of any other apologies for absence that have come through since the last update? Okay, I'll take the silence as a no there. Okay, so I'll just move us on to declarations of interest. Could members of the committee with any declarations of interest in any of today's agenda items beyond what has previously been declared in the register make that known to me now? Okay, again, I'm not seeing any hands going up there to declare any new declaration of interest. So the next item is questions from members of the public. I'm going to hand over to Jackie to just run through the questions that we've received, please.
Yes, so we've received one question from a member of the public. Unfortunately, they submitted this on the 7th of April into our inbox, but it didn't come through the right channels. So I have sent an apology to that person and I received a kind reply from them. So I've got the copy of the question, which I thought would be useful to share on screen, and I will read it for the record. So bear with me while I find the right screen. You just let me know if you can see the screen.
Yes.
Okay, so the questions that have come through, which we can't answer today, but we will make sure that we send a written response to this week, given the delay in terms of noting the question. So how many people, NHS staff in Sheffield have been tested for the virus? So recognising that originally these questions came in April, obviously the positions moved on significantly from then. On what date did testing staff begin in Sheffield? Have medical and nursing students been included in testing? And if not, why not? How many civilians, non-NHS and care workers have been tested in Sheffield? Is the CCG confident that at the end of this initial period of containment, followed by delay, we will know what percentage of the Sheffield population has developed immunity through having contracted the virus? Is sufficient PPE to the highest safety standards recommended for the current situation currently available to all staff across Sheffield healthcare services? How many complaints by NHS workers in Sheffield have been logged, if any, regarding the lack of PPE since the first case of COVID-19 was reported in the UK? Have hospital or primary care workers of any grade been asked, told or expected to attend their workplace during this period, February to the present, in any situation where appropriate PPE could not be provided? What stocks of appropriate PPE do Sheffield medical facilities, hospital and primary care hold at this stage? And how confident is Sheffield CCG that stocks are adequate and can be replenished at a sufficient rate for the rest of the year? And is Sheffield CCG aware of any circumstances where individuals within the Sheffield health workforce have resorted to making their own PPE or using PPE provided ad hoc via non-NHS routes? So I think we should note that whilst some of those questions we will hold information on across a wider organisation than just our own, a number of those we won't. So we'll endeavour to respond to where we can, or signpost where we can't. So I don't know if anyone has any anything to add in terms of that, but clearly we will circulate a response.
Okay, thank you, Jackie. So I'll just bring in David Warwicker for comment, please.
Hi, David Warwicker, North Locality, Sheffield CCG governing body member. I just wanted to suggest that in the spirit of answering the question that, yes, it was in April, but answering it now, I wonder if we should have answers for the antigen testing and antibody testing for questions 1 and 2.
Yeah.
Okay, thank you, David. I think that's a helpful helpful suggestion, particularly given back in April the existence of the antigen and antibody testing wasn't something that we were able to separate out. So I think that's a helpful suggestion. Can I bring in Anthea Morris, please?
Thank you. I'm Anthea Morris. I'm one of the lay members. Jackie, when did we find this email in the wrong place? Because I appreciate that we can't give an answer now straight away, and that the question does take quite a long time to answer, especially across the wider NHS patch. But how long have we sort of known that this question was there but not been able to get an answer for?
I was only made aware yesterday when the person resent the query, so we hadn't realised until yesterday that we'd missed it.
Thank you.
Okay, thank you, Anthea. Leslie Smith, please.
Thank you, Chair. Again, I think just to acknowledge there's some really good questions within this question, and as well as doing our response and getting that out promptly, given though that we have to take on board inputs from other organisations, it might also be useful just to bring that back to governing body when we next meet as a paper, because I'm sure governing body members will be really interested in the answer to some of those questions too. Okay, thank you, Leslie. That's a helpful point. Does anybody else have any questions or comments on that answer? Can I bring in Judy Robinson, please?
Yeah, it's Judy Robinson, Chair of Sheffield Health Watch. I thought there were interesting questions, and the answers will be too, and whether they could be communicated to the public in general, because I think people will be interested in those answers. Yeah.
Okay, thank you, Judy. Amir Afzal, please.
Hi, Amir Afzal, one of the GP Governing Body Board members. Just adding to what David said earlier, if we really want to make this comprehensive, then actually similar statistics should be answered under BME communities as well, both the staff as well as, I mean, I know there's a paper out, and I know Sheffield CCG is implementing a plan, but I'd be interested to see how far we've got with that.
Okay, thank you, Amir. Mandy Forrest, please.
Hi, I'm Mandy Forrest, one of the lay members at the CCG. Given this information was asked for in April, can I be clear, are we only giving information as it is now, or will we give the position as it was then? Is there any added value in doing that? I'm just not quite sure what timeline we're answering in now.
Okay, I think that's a valid point, and you know, Jackie has already alluded to the fact that the situation has moved on since the question was asked. Some of these bits of information, some of the data we have is stored in a tracker, and the picture of testing over time. And I wonder whether it would be useful, therefore, if as part of our response we can share the trends in the data, Jackie, as opposed to a single static position. I wonder if anybody has any thoughts on that from our executive team. So Brian Hughes, please.
Hi, Brian Hughes, Director of Commissioning and Deputy Accountable Officer. I would suggest, because although the question was asked in April, it's probably more relevant to provide the most up-to-date comprehensive information that we can. So David has already sort of asked about antigen and antibody, because things have moved significantly between April and where we are in June. So it would probably be more relevant to include the most up-to-date information rather than a position that was in April and a position that moved, that reports in June. So my suggestion would be the most up-to-date information, as long as it is comprehensive and includes all the aspects that we've spoken about here, would probably be more relevant.
Okay, thank you, thank you. And I can see Lee is indicating her approval there for that approach as well. So given the approach that Brian has just outlined, our governing body happy to take forward the response to the question in that light? Okay, and I'll just bring in Lee Sorsby if I can, just to feedback.
Thanks, Terry. Sorry, I always support obviously what Brian says, but actually that doing at that point. So I'm Lisa Osborne, one of the governing body GPs. I think it's fine to give answers to the questions as they've been requested, but I'm not wanting to prolong this, but if we're wanting to make it into a useful paper for governing body, I think just raw numbers might not give us the information that's being requested, because we can't understand what they mean. So I wonder if there perhaps needs to be a little bit of discussion before we turn this into a paper, because actually you want to know not just how many tests were done, but how many tests were done out of a population where we think they should have been done. Do you see what I mean, in terms of sort of ratios and percentages? So I just would be useful to have a bit of a chat about what this paper would be, not just raw figures.
Okay, so what I will do, can I suggest we take that as an action to look at outside of the core governing body meeting and feed back into the written response and to discussion for the governing body paper next time. So Carol, who is our secretariat for this meeting, Carol, could you make sure that that's noted as an action for picking up outside? Thank you. So before I move us on, anybody want to have any final word on that matter? Okay, thank you. So I'll move us on to the approval of the previous minutes. So these will be in the electronic paper pack that was emailed out for you last week. So what I will do is, can we please bring up any questions, queries, or alterations to the minutes by exception? So I will start with pages 1 and 2. 3 and 4, 5 and 6, 7 and 8, 9 and 10. Alan, if I could just bring in Alan Windle, please.
Yeah, just on page 10, the last paragraph regarding Professor Mark Gamasu, it says CHC, and I think it should be CQC.
Okay, so again, Carol, would you be able to make that amendment, please, as suggested there by Alan? Okay, any further amendments for pages 9 and 10? No, okay, thank you. Pages 11 and 12. Judy Robinson, please.
Just on minutes 70-20, and Mark Gamsu again about a task and finish group on equality and engagement. Health Watch or the voluntary sector don't seem to know about this. It would just be useful to be linked into that if that's possible.
Okay, so we'll suggest that Mark makes contact with you after the meeting. Thank you. Judy. And finally,
did sound very final.
Hi, Terry, it's Mandy Forrest here. You seem to have frozen again.
90. Brian, would
Hi, Terry, you're frozen. Right. In the meantime, I'll just take over for this little bit, if that's okay. It's Mandy Forrest again. I'm the deputy chair. So we've been through the minutes now. So can we move to matters arising, which is paper B, please? So the first one was a question from the public, which had been asked previously about workforce, and we're going to update for that in the future. We're not doing that at the moment. Is that correct?
So Mandy, I'll pick that up. So that action is still outstanding because the ACP workforce group has still not met to take that forward, but we'll do as soon as we can.
Right, thank you. So can I move on to 720, the Dementia Strategy? So we talked about it in January, and a update is going to be brought to the July meeting. Is that still on track, Brian?
So that I can confirm that action has now been completed and the strategy has been amended as requested by the governing body. So I'd request that we close that. I'm happy to share the strategy if people want to see the amendment, but it is in line with what was suggested in the January meeting.
Right, thank you. Thank you. Right, thank you. I'm sorry, I'm just looking at no, right, okay. The next one was 1320 around performance quality and outcomes report. So there was an issue around intelligence from practices on the appropriateness of bookings and how we could feed that experience back to the Yorkshire Ambulance Service. Yeah. Brian, that's still an open matter arising?
It is, and it's still paused, but it will be picked up, Mandy. It's not being forgotten about.
Right, thank you. And that also ties into being able to record demand from primary care, so we'll come back to that.
Thank you.
Thank you. And then 3520 was around our assurance framework. We were updating one of our objectives, and we're refreshing the assurance framework in July, so it'll be picked up then. Yeah. Okay. And then the improvement plan 4220, Sandy was going to draft a report looking at our cultural change programme and a survey. We've got an update today on this, so we're fine there. Thank you. 6420 our financial accounts, of course, that's on the agenda today. So we can close that matter arising today, I think. Is that right, Jackie? Thank you. And then 6520, the annual report, we can close those two actions because they have been happening, and we're looking at the final version of the annual report here today. Okay. 6820, the Care Trust action plan. We're going to have a report today in terms of our in our safety and quality report, so that will be handled. Safeguarding business, Alan. I'm trying to see.
There's a report. Hi, Mandy. Alan Will, Chief Nurse. Sorry, I forgot to Acting Chief Nurse. I forgot to mention that before. On that item, we've got a report on public regarding the safeguarding.
Right, thank you. Thank you. And the last matter arising was an email from Health Watch. We were going to respond to Health Watch about sorry, I'm just trying to work out.
I'll Mandy, could I just answer that one for you? So thank you all for bearing with my internet connection technology problems there. And true to word, these things always happen in public, so apologies to members of the public viewing there. So that final item was in response to an email from Health Watch last month. I've made contact with Judy outside of this to try and discuss the details in a bit more detail and understand sort of the specific nuances around what it was that we needed to know and needed to address. So there hasn't been a formal response in writing, but Judy and I will be meeting to discuss that, and should Health Watch require a written response, we will do that thereafter. So can I suggest that we follow that up at next governing body meeting, just to make sure that that action's been completed and we can close it down. Thank you. And thank you there, Mandy, for marvellously stepping in and keeping the meeting flowing. Okay. So I'll move us on now to the main part of the meeting. The first section is papers for approval, and the first item we have is paper C, which has been emailed separately to the main paper pack, and this is the adoption of our audited financial accounts for the financial year 1920. So I'll hand over to Jackie Mills, please.
Okay, thank you. So I'm not sure if I said earlier, but I'm Jackie Mills, I'm Director of Finance. So firstly, apologies for late circulation of this paper. You'll appreciate at this time of year we were trying to make sure that all the changes required were incorporated into the paper. Governing body members will remember that they received the draft accounts at the meeting on the 7th of May. Subsequent to that, the accounts have been audited. I would like to record my thanks to the finance team for their hard work over this unprecedented times in terms of having to work quite differently in production of the accounts, but also the work of our external auditors, who again have had to work quite differently in terms of auditing the accounts. But I'm pleased to say that that has all gone well. The accounts were considered at the meeting of the Audit and Integrated Governance meeting, which preceded this meeting. And in a moment, I'll ask Anthea just to feedback the committee's views. But in terms of the paper, I just wanted to bring to the attention of the governing body just a couple of things. So there have been no substantial changes recommended to the draft accounts. There was one minor change in terms of, not in terms of the main statutory accounts, but in the supporting statements of intra-NHS balances, where we changed recording of a transaction from an income to a recharge. The auditors are required to produce a report on their findings on the accounts, so that is attached to this report. So that's their ISA 260 report. The feedback from the auditors is that there is one unadjusted audit difference. And again, governing body members may recall when we presented the draft accounts, we noted that the final March figures for prescribing were not available at the time that the draft accounts were produced. We recognised there was a potential issue with additional expenditure incurred as a result of COVID. The final March figures showed expenditure that was approximately £500,000 higher than had been included in the accounts. But on the basis that that was exceptional, we took the decision not to change our accounts, and the auditors have accepted that. So we're just recording that as an unadjusted audit difference. There are some very small differences in terms of our intra-NHS balances that are noted in the report, but they are not significant. So in terms of the KPMG report, they have confirmed that they intend to issue an unqualified opinion on the accounts once they've received our letter of management representation, and they've concluded that the CCG has adequate arrangements to secure economy, efficiency and effectiveness in the use of resources. So I think if I ask Anthea just to feedback from the discussion at Audit Committee and the recommendations from Audit Committee, and then we can ask for the recommendations of the paper to be approved.
Okay,
Thank you, Jackie. Can I hand over to Anthea?
Thank you, Terry. Thank you, Jackie. Audit Committee met this afternoon and we considered the annual accounts as you have in front of you, and the representation letter from the Auditor's Management Rep letter, which we've received assurances of is standard. They have not put any special lines in there relating to any special circumstances this year. And on this basis, Audit Committee is happy to recommend the approval of these two documents to the governing body for approval. I'm not sure if I'm going out of turn now. We've also looked at the ISA 260, which is the letter from KPMG, our auditors, which goes through all the work that they've done. We've had an example of how they do expenditure testing this year to look at the work they actually do. And we've reviewed that, their audit opinion and their conclusion on value for money as well. So we've been through all of that and we recommend all of that in the annual report to governing body for approval.
Okay, thank you, Anthea. So can I hand back to Jackie to give us an overview of the actions required from governing body today, and then I will open up to questions if I may.
Yeah, so the recommendation is that the governing body authorise Leslie as accountable officer to sign the letter of management representations. I should just note for the record that before this meeting, we asked all governing body members to make a declaration that they'd made all information available to the auditors, and we've had 100% completion of that declaration. So we probably just need to note that for the minutes. And following the receipt of the management rep letter, we would ask Leslie to sign the element of the annual accounts that require signing.
Okay, thank you, Jackie. So if I could invite members of governing body to feedback any comments or to ask any questions now. Okay, so if I could bring in Andrew McGinty, please.
Good afternoon, Andrew McGinty, GP representing the Hallam and South locality and one of the clinical directors of the CCG. I was at the audit committee and I didn't bring it up there, but I was just going to check with Jackie because I think it's a potentially piece of very good news around primary care prescribing. On the operating expenses on page 14, the prescribing costs for this year compared to last year look like they only went up about 4.5 million. And that was against a projected risk of about 8 million. So I think that if that represents some really fine work by an engagement by our meds management team here at the CCG, but by the practices at large, doing really good work around prescribing and managing clinical conditions as best they can with the medicines and the resources they have. So it was just to point that out.
And also, Andrew, just to recognise that was in the context of significant price pressures nationally. So I think it was a difficult year in which to manage some of those, and I think it's good to note that the success in terms of managing efficient prescribing.
Okay, thank you. Leslie Smith, please.
Thank you, Chair. Leslie Smith, Accountable Officer. So I'd just like to start by endorsing Andrew's points and our thanks. In signing off the accounts, I think just recording my thanks to Jackie and the team for all of the work that you've done to make this a reality for us. So thank you for that too.
Okay, Brian Hughes, please.
It's a repeat of what Leslie has just said. I know it's Jackie's job, but I think in the circumstances, both of what Jackie and the team have done and also the circumstances that the auditors found themselves and our audit committee as well, I just want to express my thanks as well.
Okay, thank you, Brian. Are there any further questions or comments for Jackie, please? So Leslie, has your hand gone back up there? No, okay, fine. Thank you, Jackie, for presenting that. I'll reiterate our thanks to the finance team, and there is an action for us to thank that team in writing. And I wonder whether, Zach McMurray, whether you would be happy to pick up writing back to the medicines management team to thank them for, really making a very significant contribution to the prescribing and the positive bit of the budget there, and also to write out to our GP member practices to thank them as well for their hard work in contributing to this, given the financial pressures on medicines this year.
Yeah, absolutely. Really pleased to do that.
Okay, thank you very much. Okay, so I'll just take one final opportunity for anybody to raise any points before we move on to item number 8. Okay, so I'll move us on to item number 8, which is back over to Jackie Mills, please, is the NHS Sheffield CCG Annual Report for 1920.
Okay, thank you. So this follows on from the accounts clearly. So again, the draft annual report was submitted to governing body on the 7th of May. It was helpful to receive the comments and feedback from governing body members, which have all been incorporated into the final annual report. My thanks to Lucy for doing lots of hard work to get that. The paper records some very minor amendments to the annual report that we have actioned, recognising that a small number of sections in the draft report were incomplete due to management being diverted to respond to the crisis. The auditors have completed their review of the annual report, so they're required to review specific sections of the report, but also to feedback on the report in more general. So they are not wanting to bring anything to the attention of governing body in terms of the annual report. There is a statement of the accountable officer's responsibility in the annual report that if governing body adopts the report as final, Leslie will be asked to sign. So I think that was all I particularly wanted to say in terms of the annual report, but I'm happy to take any questions.
So any questions from members of governing body relating to this item, please? So Anthea.
Just to confirm, Audit Committee has also been through the annual report and also recommends its approval to governing body.
Okay, thank you. Chris Neild, please. So Chris, could I just ask you to unmute yourself for your comment? Thank you.
Sorry, I always do that. Yes, I found it was particularly useful, and thank Leslie in the introduction, because it was useful at reminding us of some of the key points about the 360-degree review, the work on COVID, and the work we've had to change to achieve that, and what's been put in place. So thank you for that.
Okay, any further comments? Okay, so I'd just like to echo what Chris has highlighted there. I think we can probably all reflect that over the past 12 months, Sheffield CCG has been on a significant journey of change, and adding into that the challenges that COVID have brought us. I think the report is very good at bringing some of that reflection together, and reflecting some of the significant work and significant effort that our teams across the CCG have put in and have achieved to the benefit of people in Sheffield. So thank you, Leslie, for that detailed introduction. Okay, and I do believe if there are no further comments, I'll hand back to Jackie, but that will then take us nicely on to item number 9. So Jackie, if you could just reread the recommendations to governing body, please.
Yeah, so we're asking governing body to approve the final annual report that incorporates the annual governance statement, and that all relevant sections and declarations are signed by Leslie as accountable officer.
Okay, so Chris, did your hand go up there for a comment? No, okay. So I will take it by exception that governing body are happy to approve the recommendations. Okay, thank you. So Jackie, we approve that paper. And as I've mentioned, the paper does reflect some of the significant journey we have been on as a CCG, and some of the significant changes we've had over the past 12 months, which will bring us nicely onto the discussion on item number 9, which is around our CCG improvement plan. Hopefully this will be the final update on this, which is a very significant milestone for us. So I'd like to hand over to Leslie Smith to introduce this item.
Thank you, Chair. Leslie Smith, Accountable Officer. So this does move neatly on from the annual report, and I was reminded in reading through this report again earlier of our starting point last July in bringing the improvement plan to governing body, and that also happened to be my first governing body. And on the day expressing how I felt honoured to have been chosen to be your accountable officer. And I think I can add to that today, I still feel honoured, and it is also a pleasure to be your accountable officer, because I think this report really captures the journey of the last 10 months, and recognising within those 10 months that we've spent the last 3 in some unprecedented circumstances that we didn't anticipate back in July. So I think this is a great report that summarises that journey, and I'd like to express my thanks to Jane and to Sandy, who've compiled the report for us. I don't know that my words can actually add to the content, and I won't attempt to do that. I think it's a really good read, and governing body members will have had the opportunity to look through the achievements that we've secured over the last 10 months. But again, I think I'd like to say a huge thank you, because that's all been possible because of the efforts of our staff, of the senior management team, and of course the governing body members, and everything that you have done in terms of engaging with the staff and our partners, and engaging with our cultural change programme. So happy to take any comments and questions on the content of the report, but really just in terms of the recommendations, to ask governing body members to note the progress, to recognise how things have had to flex to respond to COVID-19. We had hoped to be signing off every action out of our 76. We've still got a few to carry forward, but indeed we've got some huge learning from the last few months as well. And to agree that we move on to monitoring of our improvement plan each month, to actually having a regular health check report submitted to governing body, which will include some key indicators and staff feedback and indicators on our culture, and combine those with some of the early warning signs around what we hear either in exit interviews or in staff turnover and staff sickness. So marrying up some of that soft intelligence with the other intelligence that we have and how our staff are feeling. So I think that's it from me. I'll probably open it up for comment or questions, and just to secure agreement to those recommendations.
Thank you, Leslie. First, lots of hands going up here. So if I could take from Lee Sorsby first, and then Chris Neild.
Yes, thank you. It's Lee Sorsby, one of the GPs from governing body. Just wanting to echo what Leslie's just said, the huge amount of work that's gone on, and a real willingness to participate from the staff, which has just been really very welcomed and very valuable. Just really a question, again, welcoming the sort of health check that we're going to have on a regular basis, but just asking, have we got a system whereby we can sort of join up all the dots? So those soft markers, you know, from the exit interviews, or just a way of sort of bringing this all together. Do we have a system or sort of named individuals who are responsible for bringing it all together?
I think in answer to that, Lee, we have all the dots, so we have the information at our fingertips. I think it's the job now is to harness that, to bring it together and compile that into a meaningful report for governing body that allows us to have at our fingertips all of those trends, whether they be positive or negative or warning signals. And I imagine as we do our health check reporting and bring that to governing body, I think in the first few months there'll be a bit of refinement to that. So not of the data as such, but how that we piece that together and make sense of it. And I'm sure governing body members will be instrumental in shaping that.
Okay, thank you. I'll bring us on to Chris Neild next, and then Mandy Forrest. And Chris, could we just ask you to unmute your microphone again? Thank you.
Sorry, I have to have it on all the time or off all the time. Yeah, it's been a pleasure to be part of the improvement plan group, and particularly to see those actions having some impact. I think we were keen that we didn't just have a tick list, but we were wanting to get a real feel about what was happening that was different. And I think through the quality of information, that's been achieved. I do also think it's worth noting that we've had feedback about the ability to manage the COVID situation better because of that organisational change of culture and development. And I particularly wanted to recognise the staff forum in that, and opportunity for new ideas and different ways of working that we've embraced. Just a note about the COVID and the current situation. The group that we have a learning group to capture learning from that, and to be proactive at getting staff views and taking a temperature check, so we can make changes straight away, or we can make sure we feed them into this new health check process we're going to do. And thanks to Jane, Sandy, and Sarah and Helen. Thanks.
Thank you. Mandy Forrest, please.
Hi, I'm Mandy Forrest, one of the lay members. Thanks for the report, and I echo all the comments that have been made so far. I'd just like to make an observation under 315 around partnerships and engagement. I think what the last 3 months have also shown us is our relationship needs to develop and is developing with the voluntary sector. COVID has shown how agile the voluntary sector is in Sheffield, and it's become apparent, much more apparent to us, about our need to work closely and differently with the voluntary sector. So the plan in itself and the approach we've taken has been really good, but the crisis we've been in has also shown us ways of new working as well.
Okay, thank you, Mandy, for that comment. Can I bring in Judy Robinson next, please?
I endorse what Mandy has said. I think that's very true, but a particular point I wanted to make was on also on 315, the penultimate one about the urgent care review. I think it's a really good example of learning lessons and being very honest about what went wrong, what was good. And I'd really want to endorse that as a way of working to learn from things that didn't quite go right. I think that's great.
Okay, thank you. Thank you for that comment, Judy. Do members of the governing body have any further comments or questions for Leslie? Okay, so we're being asked to note the progress in the report and to approve moving over to a regular health check, which will be submitted to governing body, and in addition agree the key learning that's emerged from the work of the improvement plan. So again, I will take approval by exception here. So our governing body in a position to approve this paper. Okay, so thumbs going up there, thank you. So Leslie, that is approved. And just one thing that I have just wanted to add into there. I think this has been a great piece of work, which has been largely led by our staff. And I think this really reflects the adaptability and the conscientiousness of the staff working in Sheffield CCG. So as well as thanking the teams involved in driving this forward, there is a big thank you there to each and every one of the members of staff at the CCG who have made this happen. So I'm very pleased with that. And then the second point, just to note, is that this was brought to Leslie's first governing body. So Leslie has been with us for 1 year now. So Leslie, we are very grateful for your presence. Okay, right. I'll move us on to item 10, which is the Performance, Quality and Outcomes Report. That's paper F in your paper pack. And I will hand over to Brian Hughes, please.
Okay, thank you, Chair. And I'll do the first bit and then Alan will pick up after me on it. In terms of, this is the second edition of the performance report in its slimmed down version, recognising the backdrop that we are currently finding ourselves in the continued response to the pandemic and COVID. Nationally, it has been decided to concentrate on a small core number of indicators which are reported and reflected within the data pack which complements the report. The numbers are set within the backdrop of massive change, and the narrative of the report I would draw colleagues' attention to is almost as important, if not more important, of what the system has done as a response to the situation that we find ourselves in. No organisation that we're currently working, be that statutory or voluntary, is operating in the same way. And the last 12 weeks, it feels a very long 12 weeks, has seen a massive change in terms of how we tried to maintain and deliver services as best as we could, in as effective a way as we could, and try and minimise the impact of services. What you will see, the numbers that we are reporting on in today's report take us up until March. What we see, almost as Jackie outlined in some of the questions that were posed at the start of it, is as the situation changes. So I can report in terms of A&E activity, which is one of the 4 key metrics. We've seen at the start of the pandemic a massive fall in terms of A&E attendances and a subsequent bounce in terms of the performance as a result of that, as less people appeared. Part of that really worried us in terms of we had to keep sending messages that the NHS was open, but the public were afraid to go out. So what we are seeing week on week is an increase in number of attendances through A&E as the confidence of the public in terms of the services that we have tried to maintain and provide have continued. So we are now seeing levels which aren't at what pre-COVID levels are, but are higher than they were when we started. Likewise, primary care colleagues and GPs on the call will recognise the sort of the demands that have increased in primary care, but equally as important in any of those numbers is the way that the services have responded to be able to adapt to that. The report draws sort of examples of how some of those services have changed, be that how we've delivered appointments in primary care, how we've responded to some of the impact that has been felt on the emotional health of children and adults through that. And this will continue to be in effect. What we now are turning to as we talk to any word that has re before it, reset, recalibration, restart, it's within a context of trying to hold on to some of those changes that we have made that have been beneficial to the population and to the way services are delivered, and try and maintain those as we try and restart some of those planned services. But we do know there will be an effect on planned surgery. So indicators around our incomplete pathways around referral to treatment have been impacted because the volume of activity, planned activity that has been able to be undertaken within our acute sector has been affected. We are trying to, and our providers are trying to restart some of that activity that is within a COVID safe environment. So the volume of activity is significantly reduced and probably will be reduced for a period of time that is unknown as yet. But that is trying to recalibrate and relook at the priority order and those where treatment is needed quicker. We have tried to maintain some cancer services and some diagnostic services, which are also reported contained within the report. We have also utilised the independent sector and tried to maximise the capacity that exists there to be able to provide care again within a COVID environment that is safe and protects individuals. So as this report continues to be reported on month, we will see an impact on performance. We will start to pick up in terms of level of activity and impact on activity. But it is presented today within a context of there is a set of numbers that reports what was happening in March. We are now in June. And as we sort of go through this period, I will continue to update on the level of planned activity that is currently being undertaken and will increase, and the effect and impact that will have on our waiting lists and demand on services as we move forward. I'll pause at that point and then take any questions or comments and then move into Alan's sections, if that's okay.
Thank you, Brian. So I'll take a first comment from Lee Salisbury, please.
Hi, thanks for this, Brian and Alan. I'm not a great one for artificially imposed targets, but they do sometimes give us a bit of an indication as to how a system is working. So just picking the 4-hour target for A&E, if demand has gone down by 50% and yet we're still only hitting 90% of patients being seen in 4 hours. And from memory, you know, I've been doing this long enough to think, actually, we did used to get above that. We used to get, I'm sure, 92 or higher in the past. So is it possible to understand this? Does that represent actually a lot of staff were redeployed elsewhere? So actually there wasn't the amount of staff that was there in A&E? Or is it talking about, actually, this is a completely unmanageable target, regardless of how many patients you can come in? Or is it about a system that even when the workload is reduced to 50%, it's still a struggle to arrange itself in order to hit that target. As I say, the target itself is sort of irrelevant because we know that it isn't necessarily, doesn't improve outcomes, but it's just a way of trying to understand the system within secondary care and see if we can learn anything from this. So that's a slightly garbled question, but just to, any more sort of information behind it that it can tell us in a useful way.
So Lee, it makes perfect sense. And the indicator, the 90% reflects the position at March, which is when we were in the situation. We monitor A&E performance on a daily basis. And that's why I was referring earlier to, we know the numbers are increasing. The performance that is associated with that, as we stand this week, has been on each day above 95%, which is the operational standard. And the quarter to date is currently at 94%. So it reflects, with reduced numbers, but increase in numbers, an ability to be able to achieve the operational standard, which is 95% seen within 4 hours. But again, that is within a context of operating in a COVID safe environment. So it is with social distancing, it is in a more difficult environment around PPE and ability to treat as quickly with some of the parameters that staff are currently facing in it. But the position at March does reflect some of the difficulty of achieving the target at the height of the pandemic and the flow that was coming through.
Sorry, can I just follow? Do we know what the staffing level was? Was the staffing level reduced at that point because of the demands elsewhere within the system, or is that with the normal A&E staff?
I will check that out, but I would imagine that will be within reduced staff numbers that were redeployed elsewhere within the hospital to deal with, particularly in that March environment where numbers of admissions for COVID were increasing on a daily basis almost.
Okay, thank you.
Thank you. Could I bring in Zach McMurray, please?
Yeah, Zach McMurray, Medical Director. Brian's covered some of it. I think, to be fair to A&E, I think a lot of it was trying to work within a COVID safe environment. And the logistics of doing that within the pretty cramped environment that they've got in A&E through the design of the actual building itself. I think there's also an issue about the complexity of the patients. So they had a lot of sicker patients that were coming in, particularly with COVID, who had to be managed. And I think also there were some staffing issues because they did have some staff that either couldn't work because they had to isolate for various reasons. So I think it's a combination of everything. I think it's really encouraging that, although I'm not a big fan of targets myself, I think the fact that they're getting closer to that 95% level is encouraging and does suggest that the flow through the system is working much better. I think part of that is they're getting used to working within that environment, so they're getting much more efficient in getting the patients through. And then the great thing is that because of discharge home to assess, we are getting a lot of patients out from the other end of the hospital very quickly. So we're not getting that sort of backlog that we used to get that created the pinch point in the past. So hopefully there's a lot of learning for the future that if we can embed that, then the situation should continue to be much more stable.
Okay, thank you. Any other questions or comments for Brian, please? Okay, so I'll split the question recommendations on this paper into two. So governing body is asked to discuss and note the performance on delivery, which we have just done. So I'll move us on to Alan Windle to update us on quality, safety and patient experience. And likewise, again, if we can discuss that paper, note it, please. Okay, so Alan.
Thank you, Chair, and thank you, Brian. It's Alan Windle, Acting Chief Nurse. I want to start this section again, and I think it will be a theme, is from a quality perspective, we can't underestimate the significance of the changes in the COVID period to how the CCG is functioning and applying its duties under improvement and quality assurance. Again, another theme is a thank you to the majority of the CCG teams that are working very differently in order to continue our assurance processes. Some of those have increased, so governing body will note that we are now undertaking quality assurance committees monthly rather than quarterly, and once I complete my section, I'm sure our lay member Amanda Forrest will update on escalations from those committees that are now answering, that are now coming through monthly. What is new for public governing body is the next agenda item, which is a performance, quality and outcomes, which is the quality, patient safety and experience report, which probably goes into a little bit more depth of those changes that have taken place within the CCG and the scrutiny and the different ways of working. So the majority of the discussion will probably happen in the next agenda item than this one. But some key points here for us in this report is that the usual CCG scrutiny of quality accounts from providers. Provider quality accounts have now been extended till December this year, which by that point we would have already signed off and approved. I just want to assure governing body that we are undertaking conversations already with the trusts on their plans, and a date of provisional plans will be around the 15th of October. We continue to meet for quality assurance committees with providers and liaising with providers in between those quality meetings in order to pick up escalating issues. So in effect, while the teams are working very differently, our communication and oversight has changed and is maintaining. Just in addition to that, moving forward on this paper, you will see that quality will come out of this paper and a more formalised public patient safety and quality report will be presented in future. However, the quality metrics, some of what Lee has just alluded to within relation to the standard reporting around 4-hour waits that is tagged as a quality target, and the cancer targets will remain in this report. Happy to take any questions, Chair. Doesn't Mandy want to update a governing body on the escalations from Quality Assurance Committee?
Okay, thank you, Alan. So before we bring in further information from Mandy, I just invite members of governing body to ask questions or bring any comments to the information that Alan has just presented. Okay, so Lee Sorsby, please.
Sorry, I'm not wanting to dominate these discussions, but just thinking about moving forward, obviously the COVID experience has been hugely challenging for lots of people, but there have been some unexpected benefits in terms of new ways of working that actually have been very welcomed by a lot of patients. Thinking of remote consultations, telephone consultations, sort of really looking at what are value added contacts and actually what aren't necessary in terms of patients going to outpatients and not getting any benefit from it. So I was just wondering, Alan and Zach, what if you're able to sort of update us on the flavour of the conversations that we're having with secondary care in terms of working towards the next phase and beyond that into a new normal, incorporating sort of new ways of working, whether there's an openness to that, and also whether we've got any information yet from patients and patient experience in terms of whether this would be welcomed or not. Thank you.
Thanks, Lee. So what I'll do, just to sort of help with the flow of the meeting, if I can get Alan to feedback comments on that question, and then if we can bring Zach in, please.
So there is continued discussions throughout this COVID period about new ways of working and whether those new ways of working are are improvements, and there's quite a lot of learning that we're already understanding. And I'm just thinking around our discharges process, some of our continuing healthcare team we don't have the duty to undertake DSTs like we used to do, but actually those teams are still applying those quality issues that they did when they had the duty of the DST, but working both in community services and hospital services, ensuring prompt and timely discharges and preventions from admission. The legislation within relation to COVID relating to continuing healthcare is planned for 2 years. We are anticipating, as I say, possible changes within relation to legislation within relation to continuing healthcare nationally from learning that we would apply locally. So again, in our later report, Lee, on safeguarding, we, as you were aware, you remember on our Quality Assurance Committee, or have been attending, that they have worked very differently in supporting primary care, and we are potentially looking at different ways of working to ensure we maintain the improvements in quality of report and the performance, the actual amount of reports that are going through, once we start basically switching that tap off, once teams start moving back to their historical job roles, if they haven't changed, like our designated professionals for safeguarding, that we still maintain quality in other areas. So it is an ongoing discussion, and it will depend on when those services change, I feel, that we'll start taking those decisions as to maintaining what has improved in this period of time.
Thank you, Alan. Zach, please.
Yeah, thanks, Terry and Lee. A lot of really positive conversations happening. So, I mean, actually, we could go on for a long time discussing it. So things like looking at cases and the 10 specialities through the elective care ACP board structure, looking at if we can really take cases up to the next step, which would be genuinely getting secondary care and primary care working together to try and look at the referrals and give advice and guidance back to practices, but also looking at whether actually having access to diagnostics for the cases specialists could actually support managing some of these patients much more efficiently. Conversations around having joint consultations where you might get the primary care cases GP, secondary care consultant, and potentially, if available and if keen to do it, the GP with the patient having a joint consultation virtually. So that's 10 specialities, specifically looking at respiratory pathway, because we think post cases, there's going to be quite a lot of pressure on respiratory medicine, and really trying to join up the whole pathway. So look at the sort of pinch points within the system, why we seem to admit a lot of respiratory patients, but seem to have very good respiratory care within primary care. So can we try and support these patients? Trying to minimize the contacts. So can you actually get the system to make every patient contact count, as the buzzword we're using at the moment, or the buzz phrase. Then things like discharge home to assess. We're really pushing that this month, and it does seem to be working. So we've created extra capacity within the community to manage the patients and assess them at home. And it really is unblocking the back end of the hospital and getting patients out when they really are fit and should be at home and be managed in the home environment. So there's lots of initiatives that we're taking forward, and a real willingness. I've just caught up with Jennifer Hill, who's the Joint Medical Director at SDH this morning, really keen to try and take all of this stuff forward at pace. Now, I think some of it is one of the few things I remember from school. I think it was Malthus that said necessity's the mother of invention. So I think there is a little bit of we have to do this because we're not going to have the capacity across the system to do things in the old ways. So I think it really is pushing the innovation, and I think sort of pushing the need for the system to work together to do that, and also the big opportunity that ACP gives us to actually get that joined up working across the system. So happy to give some further updates, and I was going to maybe try and feed some of this into the citywide locality group I think we're meeting next week, so happy to update then in more detail.
Okay, thank you, Zach. I think that updated information would be most welcome to members of the citywide locality group. So thank you for that offer. Can I bring in Andrew McGinty, please?
Thanks, Terry. Andrew McGinty, GP and Clinical Director. I was going to slightly embellish Alan's report and make an ask of you that I hope governing body would support me in. In your report, Alan, point 9.3, you talk about the echo training that St Luke's have been undertaking across the system, which has been highly successful, thanks to the significant input of our most recent clinical director, Sarah Mitchell, who during Tuesday's session following her training presentation, the agenda was slightly hijacked by the Royal College of General Practitioners, who presented her with the Yvonne Carter Award for Outstanding Early Career Researcher, an award she's won for research which she's undertaken in palliative care, particularly primary care-based palliative care in children. So we're very lucky to have her and her expertise inputting not just to the CCG but to the wider system, and I'm sure governing body would hopefully support me in asking you to send her governing body's congratulations on receiving that award, Terry.
Absolutely, yes. I've communicated with Sarah personally over the matter, but I'm happy to do that on behalf of governing body. Our governing body in agreement with that suggestion. Yep, heads nodding and thumbs going up. So yes, I will write a formal letter out to Dr. Sarah Mitchell to congratulate her, but also to thank her for the significant effort she had in helping getting that ECHO group up and running, and the difference that that has made to many patients in primary care. Thank you.
Thanks, Terry.
Okay, Judy Robinson, please.
Yes, just to add to both those papers, Healthwatch is, I think, like the CCG, is doing a survey of patients in general, and then specific work, particularly with vulnerable groups, about the impact of COVID, but also about their experience of other services. And I think that will give some qualitative information, which I'd hope we could feed into this process of looking and learning about what's happened. I'd also want to pick up the 4 key areas and to see if we can match what we find to what people are saying about their experiences in those areas as well.
Okay, thank you, Judy, for that feedback. Any further comments on this section of item 10, please? Okay, thank you. So governing body has, I think, given a fairly robust discussion there to the matters in the paper, and we have noted it. So I'll take us on to item 11, please. It's paper G, follows on from the previous item, which is patient safety, quality and experience. Back over to Alan Windle, please.
Thank you, Chair. Just prior to us moving, does our lay member Amanda Forrest want to just pick up the escalations that are usually picked up in the previous report from?
Yeah, very well observed. Thank you, Alan. Mandy Forrest, please.
Hi, thank you, Alan. Yes, you'll see we've had 2 meetings of the Quality Assurance Committee, because we are now meeting monthly to make sure that we have got a grip on this. So there's a lot of what we wanted to bring to your attention, or make sure it's happening somewhere in the organisation, has already been covered in the conversation so far. But to bring to your information, we had a long talk about making sure that we're capturing insight and intelligence from primary care, and that is being fed into the system. And we talked about the networks and the approaches we use in the organisation, so that we're fully aware of the issues and how they're going through the system. We've talked about how the quality team in its widest sense has been redeployed to focus on the things that are important. And we particularly talked about infection control and safeguarding issues and how that's working. And there's been a huge focus on supporting primary care in preparing reports and documentation in safeguarding work, which has been very successful. And we're now talking about, so what's the exit plan for that so that it doesn't go in the wrong direction afterwards. We're also, we've talked about Sheffield Teaching Hospital and the action plan they're developing for addressing the Never events that they've had in the last year. And we're expecting that to come to our July Quality Assurance Committee so that we can go through their action plan and get some assurance there. Quality accounts, Alan's discussed. So we want to have a better understanding of what's likely to be in provider quality accounts earlier than December, so that we can know as an organisation how to focus on that. So there's work beginning there. We've talked an awful lot about our new relationship or a changing relationship with the Care Trust in line with their CQC report and rating, and how we ensure that our quality assurance function and our mental health transformation function work cohesively together. And so we've had a long conversation about that and how we intend to manage that within quality assurance. And we talked, there were a couple of safeguarding issues that we needed more assurance about at the time, but we've now got. One was about the Sheffield Adult Safeguarding Partnership Board, that there were some difficulties in that work at the beginning of the COVID period because of local authority IT issues and staff working remotely, but we're told that is now sorted, and so that safeguarding partnership is functioning properly now. And we've asked for some clarification with the Care Trust about their safeguarding named nurse, because their named safeguarding person wasn't Alan, help me out here, wasn't of a senior enough grade to have that role. So we've sought some assurance there. So at the end of both of those committees, we had assurance that there were ways of resolving any issues that we didn't have full sight on at that point, and that everything was being fed into the right part of the system or the organisation, bearing in mind much of it was under command and control. So I hope that's helpful to people. Okay, and thank you to all the GPs who joined the committee. Thank you.
Okay, thank you, Mandy, for that update. I'm aware that the item 10 on performance quality and outcome and some of the discussion we've had has kind of blurred across into item 11, which is patient safety, quality and experience. I'm wondering, Alan, as we move into item 11, if you could just present us with the new information that's not been discussed so far, that would be helpful.
Yeah, thank you, Chair.
Thanks.
I think what we will do, the majority is transpose over. The paper is a little bit more in depth, so I can take the paper as read, just highlighting a few key points, and then we can go to questions if that helps.
That's helpful. Thanks, Alan. Yes.
So this report has been available to provide to private governing body for a number of months while we're redoing the transition. And this is the first public paper that we've presented. So I do hope it is welcomed in giving a little bit more in-depth scrutiny of quality. I suppose the key elements on this paper, which I'd probably give a little bit more in depth to, is the inadequate rating of the Health and Social Care Trust, Foundation Trust. And then I'll take questions. So for the trust, they have moved into special measures. A regulatory group has been established, and which is a unique response, because usually we, as a system, we don't do this joined up. It's usually NHS England Improvement, CQC and CCG following different routes of assurance. But in the COVID period, we've come together, and a 2-weekly meeting has been established with the Care Trust to work through the action plan and support improvement. So our quality assurance committee moving forward will receive ongoing updates and papers from that quality review group. What I can say is that from a Sheffield Health and Social Care Trust and providing verbal assurance to a public governing body, is there's been a tremendous response and an in-depth action plan to address the issues at the trust, and an improvement programme of work called Back to Good. What I can say, both from myself sitting at that regulatory group with NHS England and Improvement and CQC, all so far, even in a short 1 month, are very welcoming of the improvements that are already commencing within the trust. So it's a really good start, and we're focused on ensuring that it continues to improve with the trust. That's really good. Other than that, internally, I've already mentioned that our CHC staff, our continuing healthcare staff, are currently supporting both community and hospital services through prevention of admission and discharge. But unfortunately, that means our outstanding reviews are decreasing, continue to decrease, but are significantly outstanding, which we continue to work through. What I can say, and it is another big thank you, in that we had a national mandate to ensure that all care homes were trained in infection control and doffing and donning, putting on and off of equipment. We had a very tight turnaround to do that, and within less than 2 weeks, every home in Sheffield had been offered the training, and 87 homes out of the 107 that were identified all had undertaken that training. And a positive message here in public governing body is that we're getting reassuring data that the number of outbreaks in our care homes across Sheffield has significantly reduced. The data yesterday was that we'd only got 1 home in Sheffield that had had an outbreak, and that had been 5 days previous. So they're on their management of that. And an outbreak is defined as having two residents with the infection. So really positive, looks like a reduction in our care homes post the training that we've implemented. I think they're the key points, so I'll take any questions.
Okay, thank you for the summary there, Alan. So I'll open up to questions and comments to governing body, please. Chris Neild.
I've unmuted. I didn't introduce myself before. I'm Chris Neild, a lay member of the CCG. I think it's really the point that you finished on, Alan, about the care homes. I know the local authority have a lead, and we've worked closely with them. And I'm pleased to see that the range of support there that we've put in, and that was no one in a escalation process. But I just wondered if you wanted, or if it would be helpful for us to hear about how that's been managed. And there's obviously been some concerns nationally over time, especially about protective equipment. So I wondered if you wanted to add a bit to that, because it's a bit of a snapshot in time at the moment, which sounds very positive.
It is. On the whole, so we've had different cells sitting under the our gold command structure. From a PPE perspective, the supply has been short, as with every other service nationally. However, our mutual aid office, so our team within the CCG, we had a system-based cell across Sheffield, including local authority, our providers, and fed into our silver and golden command structure that has managed to maintain a level of PPE for all providers in the city. That's, you know, our focus was primary care, but where we started to run short, where routes have been closed for gaining PPE, we've worked with industry to create and support us with and obtaining PPE. And again, we could have a whole governing body on thank yous to some of our systems and our partners and our staff. And I will mention Rory and Sue Lang in our team, who have done a phenomenal job just on PPE, ensuring that the flows have gone through. There's been 2 incidents across the city in this period where one practice got to the point that they were extremely low. Within 2 hours, we'd stocked them back up. And on a weekend, a care home in Sheffield had got to critical levels, and our primary care teams supported that home in establishing enough PPE for them to maintain till their supply came. So it really has been a fantastic opportunity. The CCG, along with its partners across the city, have and the list is so long. Again, I would probably take up another governing body in the support that we've offered to care homes. So we have an infection control team. We've had CHC staff supporting. We've had our quality teams who have been doing daily calls with the local authority to every home in Sheffield. And I've additionally, due to heightened concerns that we've heard through media, I have personally also undertaken some clinical visits to a care home, just to establish what the level of either risk was to patient safety. And I can say so far, while there may have been some quality issues, there hasn't been a patient safety issue.
Okay, thank you, Alan, for the update there. Nikki Bates, please.
Wanted to highlight the primary care networks and the goodwill and sharing of PPE that has gone on through this crisis, and it's been just very, very positive.
Okay, thank you, Nikki. So Mark Gamsu, please. So Mark, we have you on mute at the moment.
Yeah, I've sorted it. Yeah, hi, I'm Mark Gamsu, lay member on the CCG. We've rightly been talking about our role with regard to care homes, even though we don't commission the bulk of them. But obviously there's a relationship between people who use care homes and the health service. Another service that we don't commission is dentistry, and I'm just wondering whether it would be possible to get some view, particularly in light of the discussions around PPE. I mean, this is an important primary care service. We have ambitions for it in terms of being on the front line in terms of responding generally around health. Would it be possible just to give a brief view about how we're connecting with dentistry services, even though we don't commission them?
So just to go back, Mark, we do commission care homes to provide services. So while their routes for PPE aren't established through the NHS network, we all have a collective responsibility to ensure that wherever there's healthcare being provided, that we support that healthcare. So through a dentistry route, they will have their own lines of obtaining, ensuring, like care homes do, like primary care do, an established route of ordering PPE. There isn't any clear communications with dentistry at the moment from my particular perspective, but I can go away and check on that. But again, as with all our mutual aid, we will work as a system. So therefore, if we are able or where we can support all other forms of healthcare and in establishing good amounts of PPE for continued practice, we will do.
Okay, thank you.
Okay, can I just come back on that? I wasn't pushing that we should be responsible for PPE. I'm a little bit concerned. I mean, in the sense that in the various chains of command that we have in the city, does dentistry play in there as a service? It's a health service. How do we keep connected with that? I mean, if we're, as a city, trying to take an approach which is keeping an eye on potential sources of infection and so forth going forward, and as we move to open up a health service, I know we're not responsible for that. And I suppose my question is how are we connected?
I suppose, Mark, what I'm probably saying is, should I take that away and then come back with a response to governing body for that question? Because I'm not really clear on the routes of support for dentistry at this time to give a sufficient answer.
Okay, thanks. Yes. Okay, thank you. I think that will be a helpful response. I think, Mark, I'm picking up on obviously the kind of broader stability and safety across all of our healthcare partners being part of the question, and then the second part that I'm picking up, but maybe I've not interpreted it as it was intended. But obviously, if other parts of the system are consuming PPE, how does that connect to the things that we do commission? So I would be grateful if Alan, you could look into both points there and provide us with a response if you could. Thank you. So Judy Robinson, please.
Just briefly, dentistry has been one of the major feedback comments from patients. So I think that question, it's a PPE and a number of things, it is well made. And we found it quite difficult to get clear information to feed back to people who are inquiring.
Okay, thank you. So I will be corrected if I am mistaken here, but dentistry is something that our partners in NHS England commission. So Judy, it may be helpful to make contact with the NHS England commissioning teams around specific questions. Okay, thank you. Nikki Doherty.
I suppose, and I don't know whether this is helpful in answering some of this, but we haven't got a specific work stream within the city that looks at dentistry for the reasons Terry's just said. It's an NHS England one. We are connected into it. There's a regional primary care team, and that regional team has picked up a work stream on dentistry. We actively link into that, and we receive updates on where they are with new guidance and what's going to happen next. We monitor for any potential impact on our local place, and also for how we might engage with them if they need some support. An example of that, if we pick up the PPE example, was when we became aware early on of dentists setting up hubs. So we're now back into opening up dentistry, but they set up hubs early on. And one of our questions was not that we don't want them to have PPE, but can we make sure that we're managing that as a place, bearing in mind that. So we worked to make sure that we were not going to be compromised in any part of healthcare education as a result of dentists turning on their PPE. We also, at an early stage, linked with dentists because they were able to provide us with mutual aid whilst they were not open, and that was very helpful too. And indeed, the NHS has played a really important part locally and regionally in coordinating some of that interim dental care, because, as Judy says, it has been really frustrating for people whose prioritisation, and there's a really clear prioritisation for who should and shouldn't be seen. It has not been sufficient for them to get, for example, tooth pain and other such things. So 111 has been active in that, but also some of our GPs in helping to navigate to the right part of the city. I think it has been one of the more difficult ones because for those of you who've experienced dental pain, it is very it's very impacting on life. And yet it is one of those things that hasn't been assessed as being sufficient priority to be urgent unless you meet certain criteria.
Okay, thank you, Nikki. Mindful that the topic of this paper was just around the things that were in the quality and experience report, whilst also noting obviously that dentistry is an important part of healthcare service. I would just like to, if possible, bring us back to the content of the paper for discussion. But before that, I'll take a point from Leslie, please.
Thank you, Chair. I've put my hand down. I think Nikki raised most of the points I wanted to raise. I wanted to acknowledge the mutual aid from dental practitioners to the NHS, the move to the hubs, and some of the confusion that caused in our system, where dentistry sit in the command and control structure. But I think the key thing from this discussion, we've had to reflect on a lot of things around how we work in an integrated and partnership way as a result of COVID. And I think the key point I take from this is thinking about how our local dental practitioners play into those local partnerships going forward.
Okay, thank you. I think that's a very relevant point. And Nikki, thank you for giving us the system overview of what's been going on there. I think that was a helpful point. David Warwicker, please.
Sorry, yeah, I had a, well, first of all, yeah, I wanted to say I'm really pleased that the issue with the PPE and the being able to get PPE where people are needing it is that's the team are all over that. I'm really pleased with that. One thing that I'm just wondering, just as sort of jobbing GP perspective, is that there are procedures that are currently not happening in primary care that we would very much like to happen. And my patients, I'm getting a lot of feedback, you know, patients with blocked ears want them syringing, or people with you know, respiratory problems aren't accessing spirometry very easily, because these are so-called AGPs, aerosol generating procedures, and we don't have the requisite PPE or the fit testing at the moment to allow that to happen. I'm not sort of saying, well, we need to be doing that now, but I just wondered how the quality team or the primary care team were going to be able to help practices going forward to that sort of new normal, and how we're going to be able to start delivering those services going forward.
Okay, thank you, David. Alan, are you able to give us a brief update on the CCG position, or would that be something that is better fed back in through the citywide locality group?
I can quickly just discuss the aerosol generating procedures and the training and such. It has been extremely difficult. The CCG has attempted to support our care homes in this in delivery, because there's a number of aerosol generation procedures that happen in care homes, and the team have done, again, have engaged with care homes and managed on the whole to provide that training. The complexity part of it, David, is that the source of the FFP3 or whatever other range of masks that are required, if the supplier changes the procedure in order to do the procedure as to restart and retraining as to commence. And so therefore, again, like yourself, David, I have a beard, we wouldn't be able to undertake those unless we shaved our beards. So it is a far more complex issue, rather than people think of just supplying a set of training in order to affect and use the procedures. It's more of a localized risk assessment of who would undertake those procedures with clients that are then risk assessed, but that changes every time the supply chain changes. Too many there for me.
Thanks, Alan. I think that gives a very clear overview of how complex personal protective equipment is. So David, if it's okay with you, we will pick up some more nuanced information about that support through the citywide locality group in due course, and feed that back out to practices as we begin to attempt to try and switch on some of those routine things, as you mentioned, like ear syringing. Okay, I'll take one final point on this item from Andrew McGinty, please.
Thanks, Terry. I know you were trying to effectively close down the conversation on the appetite for a piece of work looking at dentistry, but I think if you're going to do that, you also need to look at optometry and community pharmacy and any other community-based NHS service that we don't commission, because there will be impacts there too.
Absolutely. I think it sort of draws back. Nikki gave us a very detailed view of dentistry, but it is the the system-wide approach to all of these services that is the key to making this successful. So again, Andrew, thank you for bringing up the other services in primary care that are not directly commissioned there. Okay, so the governing body was asked to consider and accept the report. I think we've given it quite a bit of detailed consideration, and I'm assuming everybody is happy to accept that report. So if anybody is not happy with accepting, please make yourself known now. Thank you. Alan, back over to you for item 12, which is the Safeguarding Assurance Report. So Alan, you're still muted at the moment. So I'm just wondering if you would be able to unmute yourself and update us on the Safeguarding Report, please.
Apologies, Chair. I had gone halfway through the report before realising. This report was a request of the governing body a little while ago for us to have probably a bit more in-depth of safeguarding within relation to what was happening in the COVID period. It was about 2 months ago requested. So this report basically is covering the functions of what safeguarding team are currently involved in, including what they are delivering, particularly in the COVID-19 period. I think a key point of the report, and I will take it as read as again, so we can move on to questions, is that I think we have to recognise that there is this period has raised us significant concerns within relation to the number of children, young people and adults that potentially could be put at risk, not only of safeguarding, but domestic violence, domestic homicides. And just to highlight to the public committee, I think in a period up to the end of May, in the period last year nationally, there'd been 2 domestic homicide reviews nationally. Nationally in that same period, there was 16. So that kind of highlights a comparative from last year to this year within relation to the safeguarding remit and the complexities, because the eyes on vulnerable adults, children and young people are reduced in this period. The other key points is that, again, we've alluded to on a number of occasions at private governing body and this governing body, that the function of the safeguarding team has changed in this period. Another point I'd like to highlight, and it's probably for all the other reports that have been presented here at governing body, is that the guidance and legislation on any given report here literally could change prior to it being presented here at governing body. So, for instance, the safeguarding processes are imminently going to be returning to what is normal, what we would have been looking at prior to COVID-19 as a form and function. So in the next few weeks, we will be presenting and looking at how particularly safeguarding in this report, where it presents its supporting a package to primary care. How do we continue to maintain the quality of report writing and the performance of report writing as our team returns to normal function? So while it's presented in this paper, we're already thinking forward on what the new parts of safeguarding that we need to address moving forward, and we'll be picking that up through our Quality Assurance Committee. That's mainly our, so we have a designated professional nurse. We've got 3. We've got one for looked after children who is currently supporting the local authority in undertaking adult health assessments for potential foster parents. So that's quite a change to the service as well, but obviously imperative so that we can make sure that the flow of adoptions and foster carers is, is as slick as possible. Referrals for children haven't changed. So the referrals, so on one part, while we've got less oversight of children, the amount of referrals have maintained. But given the fact that we are concerned potentially in the system, as systems start moving back to normal, like schools opening, those referrals may start increasing from what the current norm is. Domestic violence referrals in Sheffield have remained on the whole the same. However, comparatively across our system, I do know in our other CCG areas, they have increased. So I do think from a safeguarding domestic violence, there is some questions for our partnership boards that have been raised, but that's in addition to this paper. So I'm happy to take any questions that anybody has, Chair.
Thank you. Are there any questions for Alan on this paper? Mandy Forrest, please.
Thanks. Alan, at one of our QUAC meetings, we talked about health visitor midwifery services linking up with primary care and the added value that brings to safeguarding. Have you got any further information on that? Because there was an example of some practices not wanting health visitors in, and then there was some examples of some health visitors not being available.
Yes, you're quite right, Mandy, and I think that on the whole, the general feeling it has been raised at the Safeguarding Partnership Board. We had an Adults and Children's Board, so that issue is being addressed through the local authority and ourselves. I don't think I've got an overarching response for you at this point, but I do believe it will come into the next governing body through our our previous quality report, because that's going to the response is flowing into our Quality Assurance Committee as a full response to that question.
Thank you.
Any further comments? Lee Sorsby, please.
Thanks. Thanks for this, Alan. It's really welcome report. And as Mandy said, we did discuss it at the QUAC committee. I suppose this is one of the few occasions when actually I'd rather have a quantitative report rather than a qualitative report, because it's reassuring to know that all the services are still present and they're still functioning. But I suppose our concern was what's happening to numbers, because as you've already outlined, there is an understood increased risk, and I think that's backed by the letter, and people have probably heard about it from the Royal College of Paediatricians today, 1,500 consultants writing to the Prime Minister outlining their concerns, because they are very real concerns. So we sort of, I thought when we discussed it at the QUAC meeting, Sue Mace had said that the numbers had reduced for children, but maybe I've misremembered that. But notwithstanding, even if they're the same, we sort of would be expecting them to be increased during this time. So there is a concern that there's an unmet need out there. And I think as well, it's interesting that the number of referrals for domestic violence hasn't gone up, whereas elsewhere we sort of think that it has gone up. So we're just, the concern is, what are we not seeing and what are we missing? Yeah. And I suppose with that in mind, my question would be, it's likely that once lockdown lifts and people are rediscovered and have increased access to services, that the demand is going to increase. And are we assured that we've got the capacity to meet any increased demand coming out of this?
I absolutely agree. I'm just checking that I wasn't on mute. Apologies. I think you're quite right, Lee. I think at board, at partnership board, we do have both adults and children's. There's a performance report, and what I probably would suggest is that we look at how we fit that into our, or an oversight of that into our quality reporting in through QAC, so that will give you more of a quantitative as well as qualitative information. So I'll seek to do that from next time if governing body feels that would be beneficial. The question around your questions around how referrals not increasing is one that I am concerned about, which I am raising with partnership board. Potentially it could mean that we've just maintained and we've kept our system as usual, so therefore, you know, everything's okay. Or you could look at it as, is our communication to isolated individuals effective in Sheffield, for them to be able to access the different ways they could refer themselves, like in domestic violence? So that's one of the questions that's going to be raised at board, and I'll ask board to the partnership board, safeguarding partnership board, to provide us a response with.
Okay, thank you, Alan, for that helpful update. Marion Sloan, please. And we'll just ask you to unmute yourself, Marion. Thank you.
Apologies. Marion Sloan, GP, citywide elected member. There's three things I wanted to say. Sue Mace has been fantastic support during the COVID time to all practices, and she's really helped with those adoption reports to try and get those children into the new families. She's done the MARAT reports and the domestic violence work very effectively. She and her team have taken all that off general practitioners while we've been diverted with the COVID work. There is a programme for passing that work gradually back to practices, which is going to be phased in between now and the 1st of August. So it's a very planned return to that work. So that's been really helpful. She's made very little song and dance about it, but has been quietly supporting primary care in the background. The thing that has perturbed me is that some practices have not made the midwives welcome in their premises. So antenatally, the primary care team have not seen those ladies and don't know the families very well. And if domestic violence happens, subtle changes in behaviour with the mum and the children and the way they interact is often picked up by primary care. Even the receptionist can see that there's behaviour there that should be noted by other professionals. So we're missing that, and I think that's regrettable, and I don't know what recourse we have, but various practices have been a closed door to antenatal and the midwives. The flip side to that, or the furthermore to that, is a lot of the antenatal care is being done elsewhere, in the library, for example, which is not a very clinical space. It's not very private. You feel that the public are looking through the window at you when you've got your big tummy out. But apart from that, they're not getting the whooping cough vaccine appropriate time because they're not within primary care, and that vaccine is a very time sensitive thing to boost the baby's immunity before it gets born. It's got to be given before 28 weeks. So there may well be other knock-on effects. And I think general practice has to open its door to the midwife service.
Thank you, Marion. You're quite right. I want to thank you for your view of Sue Mace and the team. I think that the whole team has moved forward in this, so thank you. From the midwifery issue within primary care, I do know that Sue is working with Abby Tebbs within relation to primary care and looking at and focusing on that issue. I don't think we're going to come to that issue yet, but it is within the CCG and we're monitoring that at the moment. And I would agree that a glass-fronted library is not a a good route for somebody to be receiving healthcare. I'll take your point from the whooping cough bit as well, and we'll go back, and I think we need to bring that back into the CCG to have a further discussion.
Thank you.
Thank you, Alan and Marion there. So I will take from governing body that we have considered the safeguarding report and we are accepting it as written. Okay, so no objections there. Thank you, Alan. And you'll be pleased to hear that was your last item on the agenda, and you can stand down and rest for a bit now. I'm going to move us on to item 13, which is an oral update from Lucy Ettridge on the equalities work. I would like to say, just before we move on with Lucy, that equalities is a really important consideration in everything we commission. And I think events over recent weeks have really shone a spotlight on this. So I think it's more important now than ever that as a governing body, we are assured that as a CCG, we ensure that we are meeting our equalities duties, and also just to make sure that we are able to demonstrate through what we commission that we are doing it in an equal way for all people. So over to you, Lucy.
Thanks, Chair. I'm Lucy Ettridge, Deputy Director of Communications, Engagement and Equality. I presented a paper to private governing body last month, which agreed an approach to how we'd meet our legal duties and our moral duties around equalities and involvement. And unfortunately, I've not had time to pull together a paper for this governing body, but I'll bring back one in July, which goes through in more detail. You'll be pleased to hear that since last governing body, we've continued to engage community groups, third sector, to pull together weekly insight reports, and they work themselves through the organisation. And we're actually going to pull together a big summary report that's going to go to SMT very soon. We have started to do a retrospective review of all the decisions we've made, which we hope to conclude on Friday, to give governing body assurance that we've met our equality duties, which we will publish, and with review dates of those decisions. And what we will add to that as well are the decisions that our providers have made to change any services, because if those services remain changed for more than 6 months, then the legal duty to involve will be the CCG. So we'll cover that as well, so governing body can be assured that we're all meeting our legal duties. Since last governing body, my team and the patient experience team have worked hard to pull together an engagement plan on meeting our duties on phase 2. So when we bring more services online and continue to either maintain certain changes or change things permanently to ensure that we meet our legal duties, we've appointed a market research company, and we're making really good progress working with the council and Health Watch on a joint piece of work. And the weekly engagement and insights reports we do actually feed into the citywide rapid health impact assessment. So they really are starting to have an impact. So next month, I'll bring more information back. I'll bring back the list of all the decisions and assurance that we met our equality duties. And I'll bring back more information on the engagement plan for phase 2, which hopefully the engagement will have started by the 16th of July. I'm happy to take any questions, but I thought I might hand over to Mark, if Mark wants to add anything that I might have missed out.
Okay, so yes, if you could, I've got Mark as a person who wanted to contribute, so over to Mark, please.
Yeah, thanks, Lucy. I think you've covered most. I just really want to affirm, I mean, the engagement and quality, members from the engagement and the quality team from communications and engagement have been working on this over the last couple of months, and I really feel this is tremendously important and follows really on the point that you were making, Terry. I mean, it's really, really important that we make sure that we don't leave communities behind here. And as Lucy has said, the team have been keeping a very close, a good record of changes that have been made over this period, and we need to be thinking about, well, I mean, Alan mentioned this earlier. Some of the changes that have been made may very well be ones that are positive and good for people in the city. But nonetheless, if there are changes of significance, we then need to talk to people about how they feel about those and how it's impacted upon them. and as Lucy says, we'll be proactive about bringing that work back into this governing body. I also just want to affirm that we touched on it earlier, that the role and our relationship with the voluntary and community sector, particularly Healthwatch, has been really important. And one of the things that I've again would just like to affirm is we keep an eye on and we have a range of legal duties, and we've received reports on experience and performance at this meeting. But one of the important things that community organisations do, and particularly Healthwatch, is they're not required to meet responsibilities in quite the same constrained, sometimes rather narrow way. And they bring forward voices that they're hearing from their connections. And that has felt very strong over the last couple of months and tremendously helpful. And again, I think going forward, that's something that we want to make sure that we don't lose and we build on those relationships. But from the CCG point of view, the communications and engagement team and Sarah Neal from Quality have been key to helping us start to think about that. Thank you.
Thank you, Mark. Does anybody have any questions for Lucy, please? Okay, so I see no questions going there, Lucy. We look forward to further update in due course, please. Okay, I'll move us on to part 4 of the agenda. So there is a report for noting which was considered under item D, which was the CCG Annual Report. There is the ICS CEO report for noting. Does anybody have any comments that they wish to bring up on those 2 items briefly? Okay, thank you. Any other items of business? Nobody has notified any AOB in advance. However, I am aware that Jackie has already had a response from Healthwatch about the question that was brought up under questions from members of the public. So Jackie, could you give us an update on that, please?
Yeah, sorry, it's from Save Our NHS. So they've obviously been able to listen to the live stream of this meeting, which is positive feedback, and have also clarified their specific questions, which we will take into account in responding.
Okay, thank you, Jackie. So that brings us to the end of this month's Governing Body in Public. So thank you all for joining us, and thank you to members of the public who have joined us on the live streaming on YouTube. I'd just like to comment that actually last month we had 96 people viewing our governing body online. Haven't got the figures for this month, but I would say that that's probably a record. And I think there's something as a governing body we might need to consider in opening up our business as a governing body to a wider audience in future. So certainly we'll be considering that moving forward. The second bit is just a few key messages then from today's meeting. I think we've heard about some tremendous levels of work that have gone on, both over the last 12 months, but also in the recent months in response to the global pandemic. And I think what I've heard today is the adaptability of our own CCG teams, how they've been able to adjust into different roles to support people in other parts of the system, and the degree of mutuality that's been shown between CCG staff and our colleagues in other areas such as care homes. Secondly, I think there is a really strong need from some of the discussions we've had this afternoon about us being able to view a broad health system and to be able to keep an oversight and influence of what's going on more broadly than just the services we commission. And then the third point that I think is key from today is there's been lots of innovation in COVID, which has been very positive. But I think as a governing body, we also need to be very cautious that through the pandemic, some blind spots have been created, and we must make sure as a governing body we're assured that we are looking for those blind spots in service provision, in safeguarding, and making sure that we're assured that we we are working towards sorting those things out in due course. So those are my 3 key points from governing body this month. The date of the next meeting will be on Thursday, the 16th of July at 2 p.m. For members of the public, just to notify you that that meeting has been rescheduled from the 2nd of July. So the 2nd of July meeting has been stood down and has been moved to the 16th of July. So again, thank you for everyone for joining. Lucy, would you be able to stop our streaming for us?